everybody hear me? Hi, my name is Safa Yousif,
Yes.
and it's my pleasure to join this
Yes.
conference to present my paper. Thank you. I'm going to start sharing my slides. So I'm presenting my paper, which is under the title of Nerve Conduction Studies in Patient with Lumbosacral Radiculopathy caused by Lumbar Intervertebral Disc Herniation. Background. Lumbosacral radiculopathy caused by lumbar intervertebral disc herniation is a common cause of low back pain in the third and fourth decade of life. And radiculopathy is a pathological process that affects the nerve at the root level. Now, North American Spine Society has defined the radiculopathy by localized displacement of disc material beyond the normal margins of the intervertebral disc area, resulting in pain, weakness, or numbness in a myotomal or dermatomal distribution. Now, in terms of investigations, MRI is the most sensitive test in diagnosing intervertebral disc herniation, and it's the most useful tool for identifying structural abnormalities in the intervertebral disc area. But abnormal anatomical lesion may present in patients on subjects who are asymptomatic. On the other hand, nerve conduction studies are electrodiagnostic tests that assess the peripheral nerve function, in other words, the physiological integrity of the nerve, and it can be used to evaluate patients with neuromuscular problems. Nerve conduction study can be used to assess patients with lumbosacral radiculopathy, and the motor nerve studies of the comperoneal and the posterior tibial nerve can be performed. Other nerve conduction study tests like the F-wave and the S-reflex provide information about the proximal root segment, which is the nerve root, which is the part that is involved by the pathological process of the intervertebral disc herniation. Without mentioning too much details about the nerve conduction study, I'm just showing this picture to show briefly how the recording for the common peroneal nerve can be performed, and the waveform generated for the studying the motor activity of the common peroneal nerve is called the compound motor action potential, and the parameters we study were the latency, the amplitude, and the conduction velocity. The picture here shows the recording. So these are two recording electrodes, and here we can see the stimulating electrode, and the nerve segment under the study is basically the nerve segment between these two electrodes. Now, nerve is studied at different stimulation sites, and we need to use at least 2 stimulation sites to calculate the conduction velocity. Now, moving to the F-wave, like I mentioned previously, F-wave and S-reflex are nerve conduction studies that is used to study the proximal nerve segment, which is the nerve root. And the F-wave activity is recorded after the compound motor action potential. And the parameters we studied were the latency, the minimum, maximum, and mean latency. So if we look at this picture on the left side, it shows the recording for the F-wave. A stimulus is applied distally to the motor nerve, and this stimulus travels proximally to the anterior horn cells, and from there, a response fires back down the motor neuron to be recorded as a muscle response after the compound motor action potential. S-reflex is the other test that can be used to study the proximal nerve segment, and S-reflex basically electrophysiologically recorded Achilles muscle stretch reflex, and it's also recorded after the compound motor action potential. The parameter we used was the latency, and the shortest latency among series of recordings were the variable we used. So the right side of this picture shows the recording of the S-reflex. So for the tibial nerve, a stimulus is given on the popliteal fossa, and this stimulus is carried with the reflex arc to the anterior horn cells, which in this case, the S1, and then this fires back to be recorded as an activity, and we use the soleus muscle as a recording site for our study. The rationale, nerve conduction studies have the advantage of being non-invasive, objective, and reproducible tool to assess the physiological integrity of the nerve root. In the literature, there is a contrasting evidence with regard to the use of the nerve conduction studies in assessment of patients with lumbosacral radiculopathy, and there is a limited number of published researches that address the correlation between the nerve conduction study findings and the clinical manifestations of the disease. The objectives of our study were to evaluate nerve conduction studies abnormalities in patients with lumbosacral radiculopathy and to determine the association between nerve conduction study findings and the physical examination findings. This study was cross-sectional study. Two groups of subjects were studied. The first group was the patient group, and in our study, we selected 27 patients from specialized clinic and referred clinic, and their age range between 23 and 60 years. 66.7% of the patients were male, and the control group composed of 25 volunteers among the workers and the students of Khartoum University, and their age range between 24 and 60 years. 60% of those who were recruited were male. So inclusion criteria for the patients group. The patients who had MRI confirmed L4-5 and or L5 is one intervertebral disc prolapse, and we included these two levels because they are the commonest. Beside the presence of one or more of the following: dermatomal distribution of symptoms appropriate with the MRI level of the disc prolapse, weakness on examination appropriate with the MRI level of the disc prolapse, diminished ankle reflexes, sensory impairment appropriate with the MRI level, and positive straight leg raising test. Exclusion criteria for the patient group: history suggestive of polyneuropathy or radiculopathy caused by other pathology like instability or tumor, and patients who had previous spinal surgery were also excluded from the study. The control group composed of healthy volunteers with no history of radiculopathy or neuromuscular problems, no history of risk factors of having impaired nerve function, and who has normal neurological examination. So all subjects underwent clinical assessment, their MRI studies were reviewed, and they had nerve conduction studies performed. History included duration of symptoms, the side affected, and dermatomal distribution of symptoms, and any history of weakness or sphincteric disturbance. All patients' lumbosacral MRI and reports were reviewed to address the inclusion criteria, and all patients underwent nerve conduction study, and this was performed bilaterally on both limbs. And the nerve conduction studies included motor nerve conduction study of the tibial and the common peroneal nerve, F-wave latencies of both nerves, H-reflex latency of the tibial nerve. Also, sensor nerve conduction study was carried out to exclude patients who has radiculopathy. Results and discussions. In this study group, most of the patients expressed symptoms in relation to the left side or to the left limb with a percent of 62.9%. And those were more than double the number of cases who had a right-sided distribution of symptoms, and only 7.4 has had bilateral limb involvement. Now, going to the dermatome, most of the patient or the majority of patient has had S1 dermatomal distribution of symptoms with a percent of 59.3%, and that was more than 1.5 times those who presented with L5 distribution of symptoms, and only 3.7 has had bilateral dermatome involvement. Physical examination results. The most commonest encountered abnormalities in the physical examination was the positive straight leg raising test, and this followed by impaired touch sensation with a percent of 95.3 and 55.6 respectively. Then this followed by absent ankle jerk, and this was detected in 29.6% of the patients. Other abnormalities included abnormal gait, and none of the patients who were included in this study has had any degree of motor weakness. Now, going to the findings of the nerve conduction studies. Regarding the compound motor action potential, very few abnormalities were detected, and these were in terms of reduced amplitude or reduced velocity of the recorded activity of the common peroneal or the tibial nerve. And when we compared these results with the motor nerve conduction study of the control group, there was no statistical significant difference. Now, this finding goes with the findings of many previous studies and contradicts few studies. The studies that showed significant difference between the patient and the control included patients who had motor weakness, while in our study, none of the patients has suffered from any degree of motor weakness. Now moving to the F-wave latencies results. The F-wave latencies of the tibial nerve were significantly prolonged in the patient group compared to the control group, and this goes with the findings of many previous studies. So, like I mentioned earlier, we studied the minimum, maximum, and the mean latency of the F-wave, and all of them were significantly prolonged in the patient group compared to the control group. And the maximum latency was the most significant in this study, with a p-value of 0.005. Now, when the latency of the symptomatic and asymptomatic site compared with the control group, both were statistically significantly long, and that with regard to the maximum latency, the minimum and the mean latency were not significant. On the other hand, the F-wave of the common peroneal nerve revealed no statistical significant difference between the patient and the control. And this, in contrary to study carried out by Weber in 1998, who concluded from his study that tibial nerve F-wave was not sensitive, and most of the cases of S1 radiculopathy can be detected by F-wave of the common peroneal nerve. So this can be explained by the fact that Weber has included, or in their study, more patients has had L5 or L5S1 distribution of symptoms, while in our study, most of the patient has had S1 distribution of symptoms. Now, moving to the results of the H latency, there was a highly statistically significant difference between the patients and the control in the H reflex latency. And when we compared the readings of the symptomatic and asymptomatic side, both were significantly prolonged when compared to the control group. This can be explained by the fact of the nerve prolapse or the disc prolapse usually tend to involve both nerve roots, although one of the sides usually remains subclinical. Now, moving to the test of the association, there was no statistically significant association between the findings of the abnormal physical examination and the abnormal nerve conduction study parameters. If we look at this table, the subjects who had normal physical examination were 6 out of the 27 total number of patients included. 2/3 of them has had abnormal nerve conduction study. And on the other hand, patients who had abnormal physical examination, also 2/3 of them showed abnormal findings in their nerve conduction studies. And the p-value for the association was 1. So we concluded from our study that clinical examination findings does not predict the nerve conduction study findings. And both nerve conduction and clinical examination should be evaluated jointly in order to assess patients with the lumbosacral radiculopathy. And in our study, H reflex latency, prolongation was the commonest encountered abnormality in our study. And these are some of the references that I used. And thank you everyone for listening. I'm just sharing this beautiful picture of the Cantor Yard of Faculty of Medicine, Khartoum University, where this study was conducted. And now I'm happy to answer any questions.
Thank you, Dr. Safa Yousif. That was a wonderful talk. And I would like to request the participants, if you have any questions, please ask. Okay, do we have any questions for her?
I have a question.
Okay, please.
Thanks for your presentation, Dr. Yousif. It's a very interesting topic. As a spine surgeon, I only use nerve conduction test when there's controversy about the diagnosis. The radiculopathy, the patient has very typical or classical symptoms, and then the MR, just like what you said, MR and CT images confirm the diagnosis of disc herniation or lumbar stenosis. Generally, most is disc herniation, right? The compressing the nerve root. Sometimes, if the patient has radiculopathy symptoms and medical images does not find any abnormalities. Now, nerve conduction can be used to exclude any peripheral neuropathy. So you know, your readouts, your other counts, really really make me very impressive about the readouts, because generally speaking, periphery nerve pathology like the lumbar herniation, you know, as my thought is, it should be presented through nerve conduction test, right? But the result is not like what I thought.
Yeah, that's very correct. Actually, we followed this study by another study that we used MRI as a variable as well, and we concluded, like what you said, if the MRI failed to show abnormalities, then comes the role of the nerve conduction study. So MRI is superior on the nerve conduction study in terms of superior in terms of being more sensitive in detecting abnormalities. But if you fail to find any abnormalities in the MRI, then comes the role of nerve conduction studies and maybe EMG as well. Yeah, that's very correct. I totally agree. It's not very widely used, but studies showed that you can find abnormalities, and even you can use it to monitor patient post-operatively. You can see if there is any improvement in the nerve function, and you can also use it to detect recurrence.
Thank you. Thanks for your answer.
Thank you.